inviting the speakers. Let's discuss what voice uh, is all about. Yeah. Sorry. Is my screen visible?
Yes.
Yes.
Good. Voice is the abbreviation voice of impact for cancer equity. It is a collaborative initiative of between the Global Focus on Cancer in the
Sorry, some people cannot see your screen. I think stop and share again.
Okay, thank you. How about now? Yeah, voice, uh, Voice of Impact for Cancer Equity. It is a collaborative initiative made realistic on collaboration of Global Focus on Cancer in the Arctic. It is a regional initiative to strengthen the advocacy on women's cancer in Africa, to equip various group of people, people with lived experiences, civil society organizations, policymakers, researchers, and the clinicians with knowledge and the tools for policy level advocacy. And its major focus is to building knowledge and skills, and also the partnership between the African organization on working on cancer advocacy for equitable and evidence-informed policy change. The series will have four webinars, which is almost done every month. The webinar one is the one we started today. It is titled as Advocacy and Meaningful Engagement. And the next webinar will be on July 1 on policy mapping and analysis to discuss how to use the policy frameworks and the tools and resources to assess and influence the national council policies. The webinar 3 will be the stakeholder mapping and engagement in August. The webinar 4 will be the from advocacy to action in September, which help to gain the tools and the skills to integrate the advocacy into national and local cancer care policies. So we are we want to thank all the steering committee who has been working tirelessly to make this webinar series realistic as they are displayed here. All of them are the voice steering committees, and we are very thankful to them. And they are all the cancer advocates, mainly in Africa and international, working internationally, and we are very thankful to them. And special thank goes to our sponsor, who is Pfizer, for their generous support of Voice Initiative and for their commitment to continue supporting similar initiative to amplify the voice of those driving change in cancer policy and care, especially focusing on the relatively marginalized group, still the most affected one, or those people with lived experiences. Thank you very much, Pfizer, for your support. So today, we will learn from amazing speakers on understand what meaningful engagement really mean and why it matters in African setup. And we will learn also the WHO global frameworks and how to apply in action in African context. We will hear on the real world experience from the Ugandan team, which would be very exciting. And also you will share your perspective and connect with other advocates for the equity in cancer care in the region. So our amazing speakers will be Dr. Maya Olson, Dr. Julie Trudeau, and Dr. Gertrude Nakikunde. And I will introduce them later on. And all the speakers, thank you very much for being here today. So let me start by asking these questions for all our participants. Please, what is the one word that comes to your mind when you think of advocacy? You have the link in the chat box. Please use that link and give us some of what you think when you think of advocacy. Let's take 1 or 2 minutes for this. You can put in the chat box. Yes.
Sorry, Dr. Binia, my chat box is not working. I don't know why.
Okay, our technical team will solve. Please, others also, we got the equity. When you think of advocacy, please think what you think of what comes to your mind for the participants. Absolutely. Engagement, all right. Justice, of course. Thank you so much, all the participants for your ideas. So we directly invite our speakers now. Let's start with Maya Olson. I'm pleased to introduce Dr. Maya Olson, a technical consultant with the WHO Global Coordination Mechanism, where she leads implementation efforts for WHO frameworks for meaningful engagement. Maya brings deep experience in advocacy for non-communicable diseases and poverty-related health conditions, having worked across 22 countries through the Partners in Health and the NCDI poverty networks. She is also a cancer survivor and a strong advocate for the inclusion of lived experiences in health policy and system strengthening. Maya, we are very honored to have you here. Please, the stage is yours. You have 10 minutes.
Thank you. And I'll switch to slides, and it's really an honor to be here, and I appreciate you having our team from WHO. I'm going to talk kind of broadly about the WHO framework for meaningful engagement of people living with NCD's mental health and neurological conditions, but get into a couple of different things within that. For those that don't know me, I've been a lived experience advocate in this space for a very long time. I was helping support NCD and cancer advocacy with Partners in Health, an organization that works across a number of countries in the African region for quite a few years, as well as involved with global oncology and a couple of other projects around cancer education materials. And a lot of the work before WHO that I really loved the most was around advocacy training and capacity building. And so it's really great to see efforts like this continue to move forward. I helped lead the Voices of NCI Poverty Advocacy Fellowship for quite a few years, and working with advocates across regions to kind of open up opportunities to be involved with WHO and UN level advocacy, as well as kind of capacity building and training. So it's exciting to be here. Um, uh, a lot of the work that I was doing with advocates from the civil society end of things and across kind of lived experience peer networks in the last few years that I was on the civil society end of things was around the WHO framework for meaningful engagement. WHO was coming to the table with a group of about 700 of us to help co-create and develop the WHO framework. For those that aren't familiar with the document itself, it's quite an extensive resource, and I would encourage folks to take a look at it when they have the time. The first half of the framework is really focused on the why for meaningful engagement. What underpins a rights-based approach? How do we get there? Why is that so important for improving health outcomes? And then the second part of the document is really focused on principles, enablers, and recommendations for WHO and member states for how do we work with people with lived experience, and build these participatory, more equitable approaches to policy setting, but also program implementation and kind of all levels of programs, policies, and implementation. And a lot of the work of the framework and implementing the framework is housed within the WHO Global Coordination Mechanism, which is where I work, which is a member state-led mechanism that's advancing multi-sectoral action and multi-stakeholder engagement. But for a lot of you, you would have come across meaningful engagement and work with WHO across the organization, whether that be the WHO Afro team, the EMRO team, or the cancer technical team. And one of the things that the framework allows is for kind of an all of WHO approach. We talk about all of government approach, but to really have the framework underpin so much of the work across the organization. Um, and uh, and really it's about this sort of commitment to meaningful engagement and to thinking differently about the way that we think about expertise, and really centering lived experiences expertise and opening up pathways for people with lived experience to co-create and enhance related policies, programs, and services, and trying to balance the scales a little bit across where we've traditionally looked towards expertise on a more kind of biomedical, quantitative, academic, clinical route, and really kind of balancing that with the qualitative experience, lived experiences expertise, and more of kind of the civil society voice to the way that we're looking at evidence. For those that, again, haven't spent as much time with the framework, the way that WHO defines meaningful engagement is the respectful, dignified, and equitable inclusion of individuals with lived experience in a range of processes and activities within an enabling environment where power is transferred to people, valuing lived experience as a form of expertise and applying it to improve health outcomes. And I imagine through the voice webinar and through the work that you'll be doing together over the next couple of weeks, you're going to be digging into so many of it's a complicated definition, as many WHO definitions often are, but breaking down some of these, there's such essential concepts within all of the pieces of this that I'm excited to sort of hear where your discussions go in the breakout groups, and throughout this webinar. Within the framework, and again, there will be QR codes in a number of different places through the slides that you can access either in the session or after the session as you're looking through the PowerPoint. So I won't spend a ton of time on this, but there's a set of principles and a set of enablers. And for each of the enablers, sustainable financing, redistributing power, elimination of stigma, integrated approaches, capacity building, and formalizing engagement. The framework kind of builds out a bronze, silver, and gold kind of a approach to allow member states and WHO to look at the recommended actions and really sort of place themselves along a continuum and try to look at what are the next steps for building out from where they currently are. So it's a very adaptable framework. It's really built around kind of each country, each region being able to look at the recommendations of the framework and the principles and enablers and setting their own priorities about what needs to build and grow in their own region, in their own country. There are a lot of other publications and participatory research that has underpinned the framework. So there's a number of reports, there's a video series, a lot of different materials to use as advocates in your own work with governments or in your own communities. So again, I'd follow the QR codes and take a look at some of those more extensive resources around the perspectives of people with lived experience. There's some interesting regional work that has happened, as well as a video series. And so where we are now with the framework was launched in May of 2023. There's been a lot of buy-in and enthusiasm for the framework across member states, across lived experience communities. So now how do we go from the intention of some of these principles and enablers to action? And within WHO, we've had a couple of different platforms that we've really invested in and focused on. On the global level, we've been supporting the WHO Symposium on Meaningful Engagement, which has allowed a platform led by a 9-person steering committee of lived experience experts. Carolyn Taylor is among that group. That's been a platform for the lived experience community to help influence and support advocacy around the high-level meeting and the political declaration that is in negotiations right now on the global level for 2025 to 2030. EMRA region and some of our regional offices and member states, particularly in the Eastern Mediterranean, have really invested in meaningful engagement platforms at member state level. There's a photo here of an advocate in conversations with ministry and other stakeholders in Syria about setting priorities local to what needs to move with meaningful engagement in cancer policy setting in Syria. Cancer team and NCD team across WHO. There's photos from the NCD financing dialogue, the cancer priorities exercise that the cancer team led with many of you on this call in Geneva last September. So we're really trying to build these platforms. I'm not going to spend time on this slide. This is a reference for people to look at after the session, but all of the global work and much of what kind of country and regional office has been, there's been this longer timeline leading up to the high-level meeting, which is one of those marquee policy setting moments at heads of state level. It looks like we're at the very end of the process and there's really no way to weigh in at this point. But in this kind of very critical period of time from May to September, member states are sitting down for negotiations for the first time today. And so there's a lot of potential to still be talking to your ministries of health, your missions, working in your civil society networks to help weigh in on the political declaration and nudge your governments in the way that you think needs to happen for meaningful engagement or for the priorities you care about in the cancer space to be of kind of higher priority in the political declaration. And I'll have a link to the Road to 2025 resources for you on that. Within the symposium and with the work globally, one of the major outcomes has been to come up with a united and kind of strong foot forward and a set of key advocacy messages and key asks specific to meaningful engagement that the community, the lived experience community, is hoping is reflected in the political declaration, as well as in the way that we're moving policies and programs moving forward. So again, these are resources you can take a look at after this talk. I know I'm running on time, but they're all kind of on these major themes around recognizing the right to meaningful engagement, addressing barriers to participation, formalizing and incentivizing meaningful engagement, and investing in strengthening and resourcing. And so again, in the slide deck, you can look at this kind of in the materials that are provided after the session. You can look at those 12 asks. I would also encourage you to check out the Road to 2025 and kind of the current advocacy that's referencing the current advocacy that's ongoing with the high-level meeting, as well as taking a look at the framework, the key advocacy messages, and all of this is housed on the WHO Knowledge Action Portal, which has many more resources beyond that, including a lot of the inputs that are coming through from civil society related to the political process. So I'll stop there and looking forward to the discussion.
Thank you very much, Maya, for this wonderful presentation. Please stay there. We will have panel discussion later on. All the participants can drop any questions in the chat box for Maya. So now I will invite our next speaker, who is Dr. Julie Torodo. She is also a very active member of the Voice Initiative, and she is a member of Executive Council of AURTIC and a co-chair of the Advocacy Special Interest Group in AURTIC. She is the Director of Strategic Partnership at the Institute of Cancer Policy and a visiting researcher at King's College London. Julie focuses on the global cancer prevention, control, and women's health. With a PhD in chemistry, she has worked internationally in policy and advocacy, including over a decade at the Union for International Cancer Control. Julie has also supported civil society organizations like World Child Cancer and the African Cervical Health Alliances. Julie, it is always great to have you. Please, the stage is yours for 10 minutes. Thank you so much.
Thank you so much. And I'm filling in for WHO Afro, who unfortunately couldn't join us today. So please let me know if everyone see my slides okay?
Yes, Julie.
Thank you. So what I'll be doing is talking about the global initiatives, and really I'd like to open up the discussion about how we are bringing momentum to national programs. So the first global initiative that a lot of time gets forgotten is the Global Initiative for Cancer Registry Development. This was actually launched in 2017. And for the African region, we have two hubs that are relevant. Firstly, the North African, Central and Western Asian hub, led from Tunisia, and then the Sub-Saharan African hub. And that is particularly led by the African Cancer Registry Network. So if you're not familiar with cancer registration, that's a good place to start to find out, do you have a cancer registry in your country? And particularly, we're talking about population-based cancer registries. And why is that important? Well, you need to have capture a whole population of at least 1 million people to be able then to develop data on the incidence of cancer and hopefully over time also the mortality data. These are all the data that then feed into the GloboCan database, which we often go to look at the global statistics for cancer. And I would like to add also that a lot of African registries do contribute to those global statistics. There's a bit of an urban myth that the GloboCan data is different to national data. But in fact, it's increasingly getting more African data feeding in. And we have over 14 cancer registries that have the level of completeness and quality that means they're contributing to that global database directly. One important thing to remember is also members that are part of the Cancer Registry Network here commit to creating a 3-year report on cancer data in the country. So even if it is just incidence data, you should be able to access national data there. And we know as advocates, data is always important. So it's important for you to get to know that cancer registry. And as you can see from the African Cancer Registry Network webpage, they also offer training, do some collaborative research, and develop some resources. So if you don't have a population-based cancer registry in your country, it's also a great advocacy push to direct your governments to this resource and start the process of putting one in place. I will move to the next initiative, the Global Initiative for Childhood Cancer, which has a strategy called Cure All. And the aim is to focus on 6 high burden cancers in childhood cancer: acute lymphoblastic leukemia, Burkitt's lymphoma, Hodgkin lymphoma, retinoblastoma, Wilms tumor, and low-grade gliomas. The reason being that we have high overall survival internationally, and you can see those on the right-hand side. And the aim in the next 5 years by 2030 is to get to at least 60% survival of childhood cancers, in those cancers in particular, but ideally all cancers. And that would save 1 million additional children's lives that are currently being lost to cancer. So it's an exciting initiative that's been going since about 2020. And the other interesting area is that there's going to be a global platform for access to childhood cancer medicines. That's just started with a cohort of 6 countries, and they aim to build to 50 countries by 2030. So offering childhood cancer medicines for free. So that's also an exciting area for advocacy to make sure that your country is aware of this initiative. The first countries to be involved from Africa are Zambia and Ghana. So again, if you have contacts there or you're working in those countries, it's an exciting area to learn more and get more involved. But our focus is very much on cancers in women. And this is one of the initiatives that has been launched by Dr. Tedros, the Director General of the World Health Organization. The reason he did that is the high disparity in incidence and mortality of cervical cancer around the world. And if you look at the ranking of mortality due to cervical cancer, 19 of the top 20 countries in that listing will be in sub-Saharan Africa. So on the right-hand side, you see the global strategy. And the key thing to know about this strategy is that it was endorsed by all member states. There is actually a resolution supporting this strategy, which means all governments that are part of the World Health Assembly have ratified basically the content of this strategy. So what is it asking for? Well, it's asking us to work together as a globe, as countries across the world, to eliminate a cancer for the first time. What you might not know from the experience in your own country is that cervical cancer is completely preventable through vaccination, through screening and treatment of cancers at the pre-cancer stage, but we can also cure cervical cancer if we find it early. So what this strategy sets out is a 3-pronged approach to eliminating cervical cancer. It's calling for 90% coverage of girls to be fully vaccinated with the HPV vaccine by age 15. And then for women of screening age, we're asking to achieve at least 70% coverage with a high performance HPV test by age 35 and then by age 45. Making sure that we also follow up with treatment for those women that are found to have lesions. And we're aiming to get 90% follow-up of women at a minimum. And we're also wanting to provide 90% coverage of treatment to women with cervical cancer, ideally at the early stage as programs mature, but also making sure that we have palliative care and pain relief available for those that are suffering at a later stage. So the key thing to remember about this is that all our governments have committed to this strategy. So if they're not doing things, it's a great opportunity to advocate. And I'd like to point to the 2 ladies on the front cover of this strategy. On the left-hand side, we have Millicent, a cervical cancer survivor, who has been so supported by groups in Kenya that she was highly motivated to change the situation in her family by making sure her daughter Grace on the right-hand side was the first girl to be vaccinated in Kenya when HPV vaccine was rolled out. And I think the important thing around this is to remember that it's an opportunity to change the mindset of our communities, particularly where we see cancer as a death sentence in many places. This is a true opportunity to talk about the opportunities to prevent cancer and open up people's minds to thinking about engaging with the health system in that preventive mindset and not waiting until we have cancer. And we know that that can be beneficial for other cancers too. The third initiative I'd like to introduce is the Global Breast Cancer Initiative. It aims to reduce the global breast cancer mortality by 2.5% per year by the year 2040. Now, that might not sound as though that's a lot when we know that it's one of the biggest killers of women, but that adds up to 2.5 million reduction in cancer deaths due to breast cancer by 2040. So again, this strategy has three-pronged approach, the 60-60-80 targets, again to be achieved by 2030 and then maintained through to 2040. So the first is about health promotion for early detection. What we'd like to achieve is that at least 60% of all breast cancers are detected at stage 1 or 2. I'm sure many of you know that the majority of breast cancer at the moment in Africa is diagnosed much later at stage 3 or 4. So that's quite a big shift and a strengthening of health systems to enable that to happen, as well as a strong public education to improve awareness and encourage women to come for screening with a clinical breast exam, or to, when they know, if they know what the signs and symptoms are, to come and seek help early. The second target, also 60, refers to the 60 days to a confirmed diagnosis. That can take some time with getting to the right place to recognize that it might be cancer, getting the right imaging, the right pathology tests, and getting those results back to your clinician that might make your treatment decision. So we have to have a really big push about making sure all of those data come together in the right time, which is why we have that 60-day limit. And I'm sure many of you know that your country is a long way from hitting that 60-day limit, at least for all. Sorry, yes?
Sorry, we have a problem with the French translation. There is a comment on the chat.
For comment for me or comment in general? Could you
Samira?
I believe that the French translation has a problem right now.
Yes,
Okay.
It's not
we
happening?
cannot
So
hear
carry on, we
anything.
will see how to correct it.
Okay.
Am I speaking too quickly? I thought I was trying very hard to speak slowly. Or is it just a sound issue?
I think it is a technical issue.
Okay.
They listen, they get us to know. You are speaking very well, and
So I'll continue and hope that the interpretation can catch up. So pillar 3 is about the comprehensive breast cancer management. We want at least 80% of all women with breast cancer to get access to treatment and to complete that full course of treatment, ideally decided upon by a multidisciplinary team. We're a long way away from that in Africa, with a lot of women not able to access care, and particularly not able to afford care, with high out-of-pocket expenditure still very much in play. What we're seeing in this initiative, and it started a little bit later, is the emergence of some useful resources, and particularly an implementation guide, but also particularly for advocates, a resource around patient navigation, which you may be interested in looking at, and we'll share those resources. So what about these global initiatives? So what happens when Dr. Tedros initiates a strategy? We get to a strategy. Well, in fact, what's happened with the Cervical Cancer Elimination Initiative as a good example is we have a whole suite now of resources that are helping guidance in those 3 pillars, and really urging governments now to take that guidance and develop programs, not just to run the program, but to really achieve those 90, 70, 90 targets. And that will be the same for all of these initiatives. So the idea is to shift from that global focus around what to do and actually now look at implementation locally in your country, and of course getting that impact and hitting the targets of each of those initiatives. One thing that is happening in the WHO Afro region, so the African Sub-Saharan Africa, is the WHO Afro Integrated Women's Cancer Project. And there's still a lot of information to emerge on this project. There's not much in the public domain, but the rationale is clear. If we look across Africa, it doesn't matter where you come from, women are dying of breast and cervical cancer in all countries, and the number 1 is either breast cancer or cervical cancer in everyone's country. So absolutely the right thing for WHO Afro to be focusing on. What we are seeing is the project is looking at integrating breast and cervical cancer services, right from that public information and detection to screening, treatment, and care of cancer services. And the aim of the project is to really look at integrating breast and cervical cancer services and building on the cervical cancer screening services that are already in place in most African countries. The pilot countries will be Kenya, Cote d'Ivoire or Ivory Coast, and Zimbabwe. So if you're from these countries, maybe you can get involved. And if you're not from these countries, maybe you can get connected with people that are involved in this project and start to learn from them as soon as possible. And for my final slide, what about us as advocates? What next when we've seen these global initiatives? Well, we definitely need to push for national breast and cervical cancer strategies, or in fact, we can follow the lead from WHO Afro and look at an integrated breast and cervical strategy. And maybe from our perspective, when we think about women engaging in communities, we could encourage our governments to think about advocating for inclusion of other cancers important to women, particularly ovarian and endometrium cancer that are killing many women in terms of volume. But what I would urge you to think about when you're talking about your advocacy with policymakers is please do not forget the education of girls and young women. We need to boost the general cancer literacy across Africa and African families with decision makers in African families, which quite often aren't girls and women. And we also need to press for more research. We really need to understand what women know about cancer and build meaningful engagement, education, information, and communication materials that are talking to those issues and improving understanding and improving uptake of these screening and early detection opportunities. And just a flag coming soon from Aortic, we will be working with advocates to develop IEC materials, so information, education and communication materials on breast cancer. These will complement those already developed by ACHA, the African Cervical Health Alliance for Cervical Cancer. So we look forward to engaging you more as that project gets going. So that's the end for me at the moment, Bingham, and back to you. I'm happy to share and respond to questions as they come through.
Thank you so much, Julie, for this insightful and informative presentation. Please, at the end, we will have a panel discussion and then you'll wait up there. So now I will kindly invite our third speaker, the inspirational Gertrude Nakigunde from Uganda. Gertrude is a breast cancer survivor, a co-founder and the CEO of the Ugandan Women's Cancer Support Organization. For over 20 years, she has led the cancer advocacy and community-based programs across Uganda, mobilizing survivors, building partnership, and advocating equitable access to cancer care. Gertrude has contributed to the Uganda's breast health guidelines, served as the Uganda Cancer Institute board, and support regional advocacy efforts across Africa, including mentoring new survivor networks. She's a passionate champion for women's voices in cancer prevention, policy, and resilience building. Thank you very much, Gertrude, to have you here. The stage is yours now. You have 10 minutes. Thank you.
Can I have my slides, please? Thank you very much for the introduction. I'm happy to be part of this important conversation. As a 23-year-old survivor of breast cancer, I have lived as a patient. I have lived as a
Gertrude, I can't
survivor.
hear you.
Oh, sorry. Thank you so much
Is it
for the
possible she's on the
opportunity.
French channel?
Yeah, because we can hear her.
I can
Yeah.
hear her.
Are you able to hear me?
Yes, we can hear you, Gertrude. Please
Okay, can
continue.
I have my slides, please?
No, we can't on the English, Binyam.
I'm on the English channel. It's coming through fine.
And it's coming through on fine. I'm on English as well.
Me too.
I'm also on English. Please, the technical team, perhaps.
Let me help you. Please, just turn off the interpreter and then turn it back on. That
Okay.
would help.
Did you? Okay.
Gertrude,
Allow me to turn off my video now that I'm not a robot you have seen.
Okay.
Thank you so much for the opportunity to be part of the speakers today. And as a survivor and an advocate, happy to be here. Next slide, please. I start with this statement from WHO as far back as 2008 to encourage advocates and assure them that policy advocacy is as far back as that time, but it is to inspire the advocates and be sure that advocacy is part of programming regardless of where we are. And as from the previous speakers, we've heard about the initiatives, the frameworks, and the resources. We cannot push without the guide from WHO. So we can push for these guidelines and initiatives to be part of our programming and be sure that we serve our communities. Next slide, please. I was asked to share practical advocacy approaches that I have used in Uganda, and these are based on the building blocks, WHO building blocks. These are tools to help us advocate. One of the blocks that we've used in movement building, I had an organization of survivors. As 20 years back, we were 5 survivors. To date, we are over 200 survivors. And in advocating, we need the critical masses, we need the numbers, and we need the voices together. So these survivors and families, we make a voice that can advocate and can ensure when we are meeting policymakers that we have the numbers. Collaborations and partnerships. We have collaborated with various institutions, academia, hospitals, in terms of research, in terms of programs. We work with the Uganda Cancer Institute to conduct research, and as survivors, we are part of the research teams. We write research projects together. We are co-investigators, we review research documents, and we disseminate these research documents together. So as collaborators, we can't work alone to advocate, but we work with partners to ensure that what we are working for, we can achieve it. As advocates and as an advocate and as other advocates in Uganda, we provide the input. We were very fundamental in the development of the National Cancer Control Plan. We were part of the technical working group, and we were responsible for writing the survivorship and the rehabilitation section. We reviewed it and made sure that all that we needed to be part of this guideline is included. We have been, and I personally been part of the Uganda Breast Health Care Guidelines, the first of its kind. And we thank Julie, has been as a great support to this work. for the last 2 years, and we have this approved by the Ministry of Health, and we shall be launching it anytime and use it as advocates. We have had direct engagements and patient representation. I have been representing cancer patients on the board of directors of Uganda Cancer Institute to ensure that the patient voice is heard, presented, patient issues, community issues are brought at a table, and we give honest discussions and a conversation without, as part of the dialogue. Engaging grassroots gatekeepers and community leaders. Our core business is with the communities as we go to increase awareness in the communities, as we mobilize women to come for screening, as we mobilize the children, the girls to come for the vaccinations. We work with the community leaders. For example, the herbalist, the cultural leaders, the religious leaders, and these have been part of our voice in the community. Communities for the advancement of cancer prevention in Uganda. Next slide, please. Next slide. There is always a gap. There is always a gap between the community. Oh, sorry, back a bit. There is always a gap between the community and the decision makers and the policy makers. And this gap, before we look at how to bridge these gaps, the voices from the community up to the leadership, one of the barriers, we have quite a number of barriers that hinder these voices to reach where they reach for advocacy. We have lack of trust in the health system. So I think all of us who come from Africa, we know how our systems are broken down and how our communities lack trust. So to advocate for improvement in this health system is a big task, but also to mobilize advocates to advocate for this, to use our own system is a big task. So there is a lack of trust in our systems, but as advocates, we work to build this trust through ongoing engagements and feedback. As we engage the communities, we give the right information, but also we bring the feedback that we get from the policymakers. There is inadequate information about cancer within our communities. We see a lot of death, and because this comes because of the misconceptions, people don't know what causes cancer. Some patients are not, some communities are not aware that there is prevention for cancer, for example, of the cervix that can save their lives. So we have to make clear communication about the goals of our advocacy, and then the facts about cancer. The referral pathways in our communities are not clear. We know our cancer care is on the top of the hem of the health care. So along the way, patients get lost. Along the way, people are misdirected and misinformed. So we keep training and empowering community champions, such as VHTs, to help communities understand the health system and the referral pathway. We have stigma and discrimination. These are quite big issues in Africa, where the stigma about cancer is too much. So many women cannot come out to advocate because of the stigma, the discrimination. They fear to participate. Some of the advocates fear to participate for fear of their jobs, for fear of unknown reasons. So we need to build the confidence in our communities. Next slide, please. Now, what have we done as an organization, as an advocate, to bridge the gaps that is between the community and the health and the policymakers? One of the strategies that we have used is creative art through theater. We have a drama group as an organization. We express our advocacy messages through song, through portrait, through storytelling. We do community mobilization and sensitization through dialogues in schools, in communities, in organized groups of women. We have group discussions of people of like-minded organizations, like men, like women, like children, like girls. So that we can audiences. We have trained and mentored community volunteers involving male champions. We know when we are talking about women's cancers, we normally forget about the men involvement. We have done a lot of male involvement, and these have been our champions and advocates at lower levels. We use peer sessions and storytelling. We make sure that we train the survivors, the patients, and the families to share their stories, their journeys. And these journeys can give us information and evidence that we can use to advocate. We do partnership with media. We cannot do this without media. Whatever we do goes through the media, and this can be observed and then watched. We have regular updates and feedback. When I'm on the boardroom, I give the feedback, I give the updates from the communities, and then I get the communities back into the community. And we do counseling and patient navigation, and we empower communities with economic skills to be able to remain advocates and remain focused on treatment, and we have success stories. Next slide, please. So I want to thank you so much for the opportunity to be part of this important conversation. As advocates, we are here to work with the rest of the team to advocate for better improvement in health and services for cancer care in Africa. Thank you.
Oh, thank you very much for inspiring presentation, Gertrude. All the three speakers, thank you so much. We will have now a panel discussion. So that the participants may put the questions for the speakers in the chat box. But if I start with Maya, from your experiences from different countries and including Africa, what is the major barriers or misunderstanding the institutions had at this time from fully embracing the meaningful engagement into their practice?
Yeah, it's a great question. And I think we've seen a lot of interest and enthusiasm for meaningful engagement. But a lot of times the barriers are, I think there's a lot of concern, particularly in resource constrained settings, that it's just not possible to do. There's so much focus that needs to happen with access to care and all of the other components of the health system. And so meaningful engagement is often sort of seen as the add-on or something that's just not a priority. It's too expensive. And I think one of the things that our colleagues are showing within WHO, you can look to some of the work in the Eastern Mediterranean region, across the African region, is there's really sort of easy, less expensive, less intensive ways than you think to introduce meaningful engagement into existing policy settings, to break down some of those barriers to getting started. A lot of people think, it has to be everything in the framework from the very beginning, and you can really build up that in a more manageable way for ministries of health and for institutions. I think we also see a lot of concern. It seems so simple, but you see a concern from kind of within WHO HQ and other policymakers that they think that people with lived experience want to replace other types of expertise, want to kind of stand in front of clinical or academic expertise. And I think it's more about working together. And a lot of people living with and affected by cancer are professionals in those areas as well. And so it's really just about recognizing lived experience as expertise in collaboration, communication with kind of the other parts of other types of stakeholders. I think some of the other misconceptions we see, a lot of times we'll get requests from colleagues who are just, we need someone living with cervical cancer, and really trying to work with institutions to identify what type of advocate are you looking for? What you need to be matching kind of lived experience experts to kind of skill sets and interest areas. It's not just finding someone who has Hodgkin's lymphoma. What is the engagement? What are the opportunities? Who has the right skill sets? What sort of skill sets need to be built in the community to be able to engage alongside some of these policy processes, and really kind of thinking through that in the same way you would think about bringing any other type of technical expert or academic voice into a certain type of engagement, to really kind of think about that in a strategic way. It is important. And then I think for those that are following the work of the symposium, I would really encourage you to look at the key asks in the barriers to engagement section, because so many of the sort of we see mistakes or misconceptions there on the institutional level of, did you consider, it's really nice to see on your webinar that translation was considered. Are travel and accommodations being done in a way that's respectful and safe for advocates to attend things? Is compensation being provided commensurate with or with extra priority to many people with lived experience are in volunteer roles or don't have the financial backing that a clinical oncologist might. And so is there additional priority being provided to what people with lived experience need to participate equitably? Is there mental health and social support being provided for people who are being very, very vulnerable in these really intimidating settings? And so kind of those sorts of additional considerations with meaningful engagement to make sure that it's as inclusive and equitable as possible. And then I think my last point is there's been so much effort around just inviting us into the room. And we really need to think beyond that. If it's not just being invited to a conference, being invited to a session, but are we co-creating? Are we meaningfully being integrated into the decision making? Are we being listened to? Are we being, and kind of what do we need to kind of shift the power relationship from, you know, being at the table to being part of the table and being involved in, and so hopefully that got to some of the sort of misconceptions we see, but.
Oh, good point, Mia, especially the one you said at last. It is more than speaking. It is all about power sharing. So all the African advocates has to work toward that. And thank you very much. I'm watching to the chat box, and there is one question for Julie. The question is like, there are several frameworks, for WHO frameworks, GBCI. So how do we translate or adapt from papers to the real world? Because in African setting, still there are a huge misunderstanding. So, Julie, what do you say on this?
Well, that is the big question, and as advocates, I think we need to define our role in making this change. So the first is to make sure you're very familiar with the documents. Make sure that you can position with your government and say, I can help create a channel to my community and share information about breast cancer, about the fact that we can cure breast cancer or cure cervical cancer and at early stages, and get that message across. So you ask, how can I partner with you in this endeavor? But I think the important thing often is that governments are not so familiar with these documents at WHO. So potentially you could get together with clinicians, invite some of the cancer planning leadership, and just present this global initiative, and just get them familiar with the targets in there. And the ideal way to bring the reality in is to reflect with some just simple collected data. It doesn't have to be a lot of patients, but reflect back the reality of the last 10 patients that were in your local clinic. How many of them were able to get their diagnosis within 60 days? How many of them were diagnosed at stage 1 or 2, and how many of them are able to access treatment or complete treatment. You can reflect that back. That opens up a conversation with many other stakeholders that can solve a lot of the other problems. I think quite often as advocates, we try and solve all of the issues. And as you've seen with Gertrude, it's not about that. It's about bringing our voice to the table and saying, you know, this is a big problem. We need to sort it out today. We shouldn't be putting it off, and pointing to the resources that WHO have, whether that's at the regional office or the national office. There are people that can help your government get going if they haven't started yet. But often there is a good base of work by 1 or 2 cancer centres in your country, and that's where you find your allies to really work and push this agenda forward, whether it's breast cancer or cervical cancer or any other cancer. But that's the type of thing that we'll be looking at a little bit more in this course of 4 webinars. So, you know, please stick with us and we'll dive in a bit more as we take the work forward.
Thank you very much, Julie. Still, people are asking questions in the chat box, and their opinion is also provided. Thanks so much. Yes, this question I'm getting from my colleague, Dr. Edom. Perhaps Gertrude also may respond to that, because Gertrude is not only a community-based advocate now, she's participating at the national level and participating in National Cancer Control Plan. So how we can bring advocates, especially survivors, to the front line and get their voices heard and even participate in the policy making. Gertrude, how do you able to get into that place, and what do you share? How do you respond to this question?
Thank you very much. That is a very good question. As we go through the survivors and supporting them, we identify skills and expertise. Some of the survivors are highly educated. They are lawyers, they are programmers, they are medical oncologists. So we use those experts and then bring their experts together with their lived stories. But what we do, we empower them. We train them and continuously mentor them to share their stories, their positives, the barriers, the challenges they've had, and how they can bring in solutions. Because at the end of the day, meaningful engagement is what I'm bringing at the table. So are they able to articulate their take at the table? Are they able to articulate their problems and then bring it part of the discussion, especially those who have fear. There are those who fear for their jobs. If I'm a medical oncologist and I'm a survivor and I know there's certain things that I may fear my boss to know, we support them to ensure that they nicely package their messages and bring them at the table.
Very good. Thank you so much. There is one more question I can see after in the chat box. In your experience, how can we localize global advocacy models to ensure they truly serve the patients in the context like ours, especially for those rural and underserved regions? Perhaps Gertrude or Maya may say something.
You can jump on this quickly, although I do have a colleague on the line who can talk about this work so much more directly than I can, from the work in the Eastern Mediterranean and North African region. But one of the things that we've been doing with the framework, because it's a big document, it's got a lot there. It's not the most kind of practically, it doesn't kind of serve practical application kind of in those 70 pages. There's so much to build from. And so what we've really encouraged regional offices and member states to do is sit down, exactly as Julie mentioned, sit down with their community of people living with and affected by cancer and look at the principles, look at the enablers, think about the context specific to Morocco or to, you know, whatever country you're looking at, and really kind of co-create a specific plan for next steps and priorities for your country, where resource constraints are and where kind of the next steps need to be. The power dynamics in different countries, or the power dynamics are different across countries, resource constraints, the civil society, strength of civil society with respect to the National Cancer Control Planning process. And so really kind of taking the big picture concepts from the framework and bringing that down to a very local priority setting conversation with ministry and lived experience, civil society, kind of stakeholders all at the same table. Hiba is on the line if she wants to jump in at any point, but Julie, what would you say kind of from the advocacy civil society end of things?
Well, I think Gertrude can say a lot more about that as far as work in country. Gertrude, would you like to add?
It is a big it's a big challenge to bring the global initiatives and frameworks up to the level of a civil society because of the resource constraints, and of course our governments have priorities. But with the little expert we have, we extract a few things that we feel are within our means, and then we always talk about them when we have an opportunity. When I was in the board of directors, I would mention what is important: patient navigation, peer support, involving survivors at different levels. And I see fruits. We are now Uganda Cancer Institute got a grant to pilot a patient navigation, a peer support with survivors. So I think that's how we can only translate the global initiatives to local levels in the given resource setting.
Okay, thank you very much for the speakers. We are a little bit out of time, but still we can have like a few minute breakout rooms where we can like discuss for about 10 minutes. And there is the French speakers there's a slot for the French speakers and the English speakers, and the technical team will allow to relocate. And for the English team, the Abigail Semenhart will moderate, and Dr. Hela Hamani will moderate the French section. So I will see you back after 10 minutes. Thank you.
Dr. Binyam, maybe people can join the group they prefer, room 1 or room 2.
Okay. Perhaps can you tell them specifically how technically how they can
just click on the room. Is it showing on the screen right now?
Okay.
It says breakout rooms at the bottom. Yeah.
And if you
So
scroll a bit,
either
you'll see the option to join, either the French or the English.
Good. See you in 10 minutes.
So are things happening because I can't?
Yeah, if you scroll down, you can choose the room you want to join.